So it is particularly something which the nurses would be the expert on the wound care. So we have Sheeba with us, who is the training coordinator at Trivandrum Institute of Palliative Sciences, Pallium, India, and she has more than 20 years of experience in palliative care. Um, she has worked in various and trained in various institutions like the Regional Cancer Center and another Institute of Medical Sciences, from where she did her um, a course in palliative care. And she is also a certified trainer for National Health System Resource Center, that is NSSRC, uh, which actually trains a lot of healthcare workers across India to spread palliative care as well as geriatric care. Um, and she was recognized as the pioneer nurse by St. Christopher's Hospice. And St. Christopher's is the first modern hospice in the world. And yeah, with this introduction, we can go into the session.
Thank you, sir, for the kind introduction. Good evening to all. Happy to see you all. So I hope you all gone through the recorded version of wound management. So this is the time for clarifying your doubts. If you have any doubts, please ask now. Am I audible?
Yes, yes.
Okay, thank you.
Anybody? Any doubts on wound management?
If you don't have any questions, I will ask few questions.
Yeah, it would be surprised.
Let me share my screen. Hope my screen is visible to everyone. So this is a case scenario. Can anyone please read it out? This case scenario. Anybody?
May
Yes, please.
Okay, so case scenario. Mr. M, 60-year-old, is a bedridden patient following fall from a height 3 months ago. He has lost sensation and motor power below umbilicus and is having sphincter incontinence. He is unmarried and lives with his older sister. Both of them do not have a fixed income. You are the doctor on home visit and find that Mr. M is having 3 ulcers, one on sacral area exposing the muscle and 2 on each heel with loss of skin. What are the stages of ulcer mentioned? There are 3 questions now. 3 risk factors and 3 preventive strategies in the care of the ulcers in these patients. How will you manage this patient?
Okay, thank you. Thank you, Dr. Aditya. And we can take the first question. And can anybody tell us what are the stages of pressure ulcers mentioned in this particular case history? It's okay even if you make mistakes. Yes, Dr. Ardra.
Hello, sir. The
Yes.
one on the sacral area, which is exposing the muscles, that is
Hmm.
stage 3, and the
Okay.
other two, which is on the each side of the heel with loss of skin, that is stage 2.
Hmm. Okay. Yeah. Thank you, Dr. Ardra. Anybody else has any other opinion?
Sacral area must be stage 4
Hmm.
and the other
Okay.
stage
Stage.
2.
Okay. Okay. Anybody else?
Stage 3.
Stage 3. Okay. So I think now I will hand it over to Sheeba.
So thank you for your contributions. The three pressure ulcers are mentioned here, one on sacral area exposing the muscles, and another two on each heel with loss of skin. So there are 6 stages. The first one is non-blanchable erythema. The second stage is dermis layer loss, that is partial thickness or dermis layer will break down. That is the second stage. Here is the heel on with loss of skin, that is second stage. The third stage is full thickness ulcer with the loss of will be affecting the subcutaneous tissue full, and the fourth stage is affecting the bone, muscle, and tendon. So this is the sacral area exposing the muscles is stage 4. So the sacral area is stage 4, and 2 on each heels with loss of skin is stage 2. Okay, and the fifth stage is unstageable, and one more stage, sixth stage, is deep tissue pressure injury. So these are the stages of pressure ulcers. Okay, so the next question. 3 risk factors and 3 preventive strategies in the care of the ulcer in this patient. So what are the 3 risk factors for this patient?
Immobility,
Very good, thank you. Then
loss of sensation,
loss of sensation, okay.
incontinence.
Incontinence, okay, very good. Any other points want to add? Anybody?
We have a response in chat as well, Shiva ma'am.
Okay. Moisture, okay. If there is an incontinence there could be a chance of moisture. So there are 3 major causes of pressure ulcer. The one is continuous pressure. The second one is moisture. The third one is friction. So these are the 3 major causes of pressure ulcers. Continuous pressure, moisture, and friction. Okay. Any other points? Okay, thank you. We can move on to the next part. What are the 3 preventive strategies? If you have seen a bedbound patient in this stage, so this is a bedbound patient, what are the instructions will give to you? Will you give to this patient and his family for preventing pressure ulcer?
Change the position of the patient.
Okay, change the position. Okay, how often you recommend?
2 to 3 hourly.
2 to 3 hours early, very good. Then other points. use air bed or water bed. Okay. So if you recommend air bed or water bed, what instructions you will give to the patient? If you suggest air mattress or water mattress to the patient for preventing pressure ulcer, they might be thinking like, okay, this will take care of everything. They otherwise, after that, they will not change the position. So that is very, very important. If you suggest these kind of mattress to the patients, so they have to change the position, because in between that in between the rows, so that pressure will be remains the same. So that area will be prone to develop pressure ulcer. So this is a preventive, this is a supporting measures which help to preventing pressure ulcers. This is not 100% preventive measures. These kind of mattress and that pillows will supporting to preventing pressure ulcers. So this is very, very important. If you suggest these kind of mattress, so you have to tell them this is a supporting device. You have to turn the patients every 2 to 3 hours. Otherwise, the patients might have developed pressure ulcer. Okay, so moisture control. So how will you control moisture?
Sheeba, there is one more comment, also taking care of the nutrition.
Okay, very good. So here there are two things. Moisture. If the patient is having incontinence, this patient is having incontinence, so there is a chance of pressure ulcer because of the continuous moisture. So what you can do is you can put a you can ask the patient to put a Foley's catheter or self-intermittent catheterization. So if they are not willing to put a catheter, then you can suggest diaper. Sometimes the diaper is also they cannot affordable, they can't afford the diaper price, so that that time you can tell them to use their own clothes. But the thing is, if there is moisture happen, they have to change the linen as soon as possible. So that is the important things you have to tell them there. And here, this patient scenario is also mentioned about. He is an unmarried and lives with his older sister. Both of them do not have a fixed income. So the lack of nutrition is also a cause of pressure ulcer. So nutrition is also important. Make sure that the protein intake in the diet is every day, so that we can able to prevent pressure ulcer formation. Thank you. Any other points? So you can think about supportive devices. You have to tell them about double SKIN. You have to keep it in mind, double SKIN. The first S is that supporting device. So whenever you have seen a bed mount patients, you have to think about a supporting device like air mattress or a water mattress. And the second thing is S is skin inspection. So whenever they turn the patient from one position to another position, like a supine position to side right lateral position or a left lateral position, they have to look into the pressure points, the important pressure points. So that if there is any color change there, we can easily to identify it, and we can able to prevent further deterioration. So the third one is keep moving. K is keep moving. Every 2 to 3 hours, they have to move the patient from one position to another the next position. And the next the letter is I. I is incontinence. Incontinence control is also important. The next letter is N. N is nutrition and hydration. So you can keep it in mind. Double SKIN for preventing pressure ulcer. Okay. So next question is, how will you manage this patient? So this patient is having 3 ulcers, one on sacral area exposing the muscles, and the another 2 on each heel with loss of skin. So we know that this is stage 4 and stage 2 pressure ulcer. How will you manage the stage 2 pressure ulcer, and how will you manage the stage 4 pressure ulcer? Class.
You can see there are 2 comments. One is wound wash with saline water and apply metronidazole powder. And by Dr. Prarthana says surgical debridement is the 5%.
Okay.
Movement of the
So,
patient after 92 hours. Dr. Mangalika.
Okay. So okay. So any other suggestion? So okay, thank you for your answers. So we all know that pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a bony prominence, result of prolonged underlived pressure. If there is a prolonged underlived pressure there is a chance of pressure ulcer formation under the bony prominence. It can occur anywhere, but especially in the over the bony prominence. So pathophysiology also, you all know that if there is a continuous pressure there, our body weight will be compressing the underlying tissue, and that leads to that if the bone weight are compressing the underlying tissues, the tissues may not get adequate nutrition, so that tissue ischemia and finally stress and breakdown. This is the pathophysiology of pressure ulcer formation. So you have to keep it in mind whenever you have seen a bedbound patient. You have to tell them so how the pressure sore develop. If you tell this pathophysiology to the caregiver, definitely they will try to change the position. And the next thing is friction. The risk factor. Risk factors we already discussed. There are lot of risk factors because friction shear is the most common risk factor. Friction for a bedbound, this patient is a bedbound. They need to change the sheets every day. When they change the sheets from sheets, so they usually that pull the sheets under the patient. So there might be a chance of friction. So before discharge the patient from the hospital, if possible, you have to demonstrate. You have to tell the nurses to demonstrate how to change that old sheets and how to put a new sheets. And if you do the home care also, if you have a nurse there, you have to tell them to demonstrate it. Otherwise, you have to learn, and you also demonstrated how to change the sheets from a bedbound patient and how to put a new bed sheets. So that way we can able to prevent friction. And shearing force. Here is a obese. You have to think about an obese patients. If you they usually slipping downwards, no? So when we re-back to their normal position, we apply more pressure, and our aim is to re-back to their normal the position. What happened because of the force, the shearing force, there might be a chance to damage the deep tissue. Okay, so then the deep tissue pressure injury can develop. So, and the next thing is impaired sensory perception and impaired physical mobility. Again, so they may not be able to sense the lower part of the body. They are prone to develop pressure ulcer. And altered level of consciousness, either semi-conscious or unconscious patients can develop pressure ulcer because of the immobility. And fecal and urinary incontinence, we already discussed, malnutrition, dehydration, excessive body height, body heat, and advanced stages. These are the risk factors of pressure ulcers. The common sites, it can occur anywhere, but from this picture you can get an idea. So based on the patient's that position and pressure, the patients can get pressure ulcer anywhere. And these are the common sites that the pressure ulcer can get develop anywhere, but it can occur especially on the bony prominence. So why I am highlighting this bony prominence is when we change the position from supine position to side lying position, you have to give a special attention on these areas, because if there is any color change there, we need to give a special attention on that area. Okay. The side lying position, one important thing, because when the patient is in right lateral or left lateral position, there is a chance of friction in between the knees, because so the knees are like knocking, or that irritate in between the knees are that friction can happen. So what you can do is you can keep a folded sheets in between the knees, and we can able to prevent the continuous pressure in between the knees. And here is the Fowler's position. We know this is the good position for a dyspnea patient, but even if the patient is on a Fowler's position also, you have to change at least 10 degree that pressure relief, because the patients can develop pressure ulcer even if the patient is Fowler's also, because this is the sacral area is the prone area, the most the important area here to develop pressure ulcer, because the full pressure is on the sacral area. So the pressure relieving here is also important. And prone is also here. These are the important areas, because if someone's can underwent a surgery, maybe skin grafting procedure, is going to undergoing a skin graft procedure, we need to put this position, because after the surgery we have to keep the patient in prone position at least 3 weeks. Before we send the patient to the surgery, we need to train the patient like this. So even if the patient is on prone position also, the patients can develop pressure ulcer on these areas. So stages of wound, we already discussed. There are 6 stages. Stage 1 is non-blanchable erythema. If you apply pressure, your own pressure on that area, your the red color is remains. That is non-blanchable erythema. And stage 2 is partial thickness with loss of skin, shallow open ulcer, or the blister formation will be there. If there is a blister formation there, definitely the skin will break down. So this is the stage 2, but there is no slough, no infection, only clean wound. And stage 3 is full thickness ulcer, subcutaneous layers will be affecting, and might have a tunneling there. So tunneling is a narrow opening or passageway that can extend in any direction through soft tissue, because if the wound has any tunneling, you have to check it properly, because when you do the assessment, you have to do the proper assessment. If the wound has any tunneling, you have to give a special attention on that area. Otherwise, wound heal fast. So because you have to give a special attention on that area. And the coming to the stage 4, exposed muscle, bone, and tendon. This is the stage 4 pressure ulcer. And the 5th stage is unstageable. So if there is a slough or a black necrotic tissue on the top of the skin, we can't assess, we can't say the stage of skin, that is unstageable. So when we document it, you have to document it is an unstageable wound. And the last stage is 6, it's a deep tissue pressure injury. this is a non-blanchable deep red purple or a maroon discolorations because as I mentioned earlier, because of the shearing force. This can happen. This is the one difference from the stage 1 and stage 6 is this is the tissue damage from inside to out. If there is a stage 1 pressure ulcer, we have seen a non-blanchable erythema, and then that layer will damage, that is stage 2. Here is a deep tissue injury because that internal tissues will damage first and then that inside out. So that is the difference between the stage 1 and stage 6. And assessment is also very, very important. Whenever you have seen a bed-bound patient with pressure ulcer, you have to assess the pain and that stages of pressure ulcer. If possible, you can think that measure the width, length, and depth. Presence of exudate, because there are exudate is oozing out of purulent discharge from the wound. Assess for tunneling. All those details you have to document it well so that we can able to do the follow-up, and after that you can you can see your treatment is beneficial to the patient or not. And another thing is the next time you might not be able to see the same patients. Your colleague will be seeing these patients. So if you document it well, it will be helpful to others also. And the management is always medicate the patient for pain is very, very important. Don't ignore it. So you have to think about pain always. If the pain is a subjective experience, you all know that we need to believe the patient words. You have to ask them if they have pain, you have to give some analgesics for that, and then wait for another 45. If you give a systemic analgesics, another 45 minutes you have to wait it, and ask them to the pain relief, and then you can do the wound management, wound dressing. So stage 1 management is the non-blanchable erythema. You can teach the caregivers to turning techniques and excellent incontinence control. So you have to prevent further pressure on that area. That is the stage 1 pressure ulcer management. Stage 2 is the only peeling of skin. There is no slough, no pus or no infection. So you can clean with normal saline. That is enough for stage 2. Stage 3 and stage 4 an unstageable wound is if slough is there, you can do the surgical debridement, and always you can use normal saline for wound cleaning. Homemade saline, you can tell them to make homemade saline, and I'll come to that. So if there is an odor or infection there, you can use the metronidazole powder. You can take a metronidazole tablet and crush it and make it a powdered form, and you can that mix with a white petroleum jelly, make a that pasted form and apply on the wound, so that the wound will get two benefit. Metronidazole will try to get control the infection, and the white petroleum jelly will give a moisturizing effect to the wound. And another thing is debridase ointment and Megahill ointment. If there is a slough there, you can use debridase ointment, but these ointments are expensive. If they are affordable, you can suggest this. Otherwise, you can use the low cost management, metronidazole, like that. These kind of cheap things you can use. And again, management, if there is an odor there, you can use charcoal pieces, and charcoal dressing is also available, but the thing is too expensive. So you can use, you can tell the patient to make charcoal pieces in their home and use that pieces in their room. Keep it in the corner of the room. That will help to absorb the bad smell. This is a good agent for absorbing bad smell. Here, on important message I want to tell you all is avoid hypochlorite solutions like povidone iodine and hydrogen peroxide solutions. Why? Is there any answers? if you use hypochlorite solutions like povidone solution and hydrogen peroxide to the wound, what happened? Tissue damage. Okay, thank you. So increased necrosis. It will damage the granulation tissues. So the normal saline is the good solution for cleaning these kind of wounds. So and then the next option is surgery consultation. If the patient's health status is okay, then if they have a stage 4 pressure ulcer there, then you can think about surgery consultation, the skin grafting procedure. If the surgeon agree the surgery consultation, then surgery skin grafting procedure, then you can do this in the skin grafting procedure. So that is the next option, and the last option is the negative pressure wound therapy. So this will help to these kind of wounds have a lot of exudate. This will help to absorb the all exudate from the wound. That will help to remove all exudates from the wound, and continues because of continuous stimulation. So that wound surface will get continuous blood circulation. Like if you do the continuous stimulation, definitely the blood circulation will increase. So that way the wound healing will effective. So this is also another option for managing the pressure ulcer. And the homemade saline and dressing supplies, these all things you have to keep it in mind when we do the home care. So this is in the hospital, we have a normal saline bottle and we have our own normal saline, but when they go back, they have to, sometimes they are not able to buy the normal saline. So that time they can use a homemade saline for cleaning that wound. They can take 500 ml of water and add 1 teaspoon of salt and boil it, cool it. So that solution they can use for wound cleaning. These kind of wounds are not a sterile wound. So this is a clean wound. The clean saline is enough for wound cleaning. Here, and also home some dressing supplies also you have to keep it in mind. If the dressing materials are finished, they can take a cotton sarees or dhotis and cut them into squares and steam them for at least half an hour, so that they can use for dressing. And prevention, we already discussed position change, manage of incontinence, special mattress like air mattress, water mattress, or pillows, cushions. So these all things we already discussed. Nutrition, hydration, and exercise is also important. If the patient is not able to do the exercise, you can encourage the caregivers to do the exercise so that we can able to improve the blood circulation. And if the blood circulation is stable, the patients won't develop any pressure ulcers. And the massage, whenever we turn a patient from one position to another position, you can look into the pressure points first and take a lubricating ointment like liquid paraffin or white petroleum jelly, or if these kind of jellies are not available, they can use their own coconut oil. And our aim is to give some massage so that we can able to improve the blood circulation and provide a wrinkle-free bed all the times. And if there is a wrinkles there, so there is a chance of developing pressure ulcer. And again, nail care is also important. If there is a nail there, they will scratch on their own skin, and then if you apply pressure on that area, the patients can develop pressure ulcer. So these all things we already discussed, SSKIN. And engage the patient and family is also important. You have to you have to think about the patient side and the caregiver side. Always we used to use the term you instead of you can start to use the word we. What we can do together and for preventing pressure ulcer. If you use the term we, So they might be thinking, okay, somebody is begging them to help them. So they will, they will, maybe they will get a supporting that persons, that feeling they will get. We always use the term you should change the version, you should give a good nutrition, you should give a wrinkle free bed, you should give what whenever we instruct the patient care, so we used to use the word you. So instead of you can use the term we, so that we can able to build a good rapport with the patient and the caregiver. So without, so from this slide, what you can understand is, without caregiver support, we can't do anything. We need a caregiver support for preventing pressure ulcer. So we have to build up their relationship, and then you have to educate the caregiver support how to prevent pressure ulcers. And if you have these kind of leaflets also, you can give to the caregiver, so that if they forget anything, they can able to look into it. Coming to the fungating wound, we all know that what is fungating wound is a cancer wound. This is the case scenario, second case scenario. Can anyone please read it out?
65-year-old man diagnosed with cancer of the right buccal mucosa, living with his family. He came to OPD for cleaning and dressing. His main complaints are pain and bleeding while removing the dressing. What could be the problem? How will you manage?
Yes, please. Anybody can try to answer those questions.
Soak the dressing well. Okay, then.
Clean towel. We have to solve the gauze with normal saline, then remove to start dressing. Injection tranexamic acid.
Give pain relief first.
So
Analgesic before.
mm. Okay. Thank you, sir. So here his main complaints are pain and other and bleeding while removing the dressing. So this is the main complaints of this patient. Okay. So here what you can understand is, so this kind of if you give a dressing to the patients, these dressings are adherents to the wound. So when we remove it, so there is a chance of bleeding and pain. So what you can do is, you have to soak well, as one of you suggest before. So you can soak well with normal saline, and then try to remove the old dressing, so that we can able to that prevent these kind of bleeding and pain. So what are the other physical problems the patients might have developed? Two physical problems is mentioned here: pain and bleeding.
Okay, many of you might have seen patients with ulcer due to cancer. And what are the complications that you have seen? I can see hemorrhage, foul smell, maggots, isolation.
Okay. So how does maggots come? Houseflies. Any other opinions? Okay, thank you. So here is also there are a lot of physical problems can develop these patients. So we all know that this is a primary or secondary malignant growth in the skin which was ulcerated and difficult to heal. So the major difference between the pressure ulcer and the cancer wound is pressure ulcer is most of the time we can prevent and preventable and curable pressure ulcer. So this is not preventable and curable. This is the major difference between the pressure ulcer and the cancer wound. So it look like a nodular fungus or a cauliflower in shape. So pathophysiology, you all know that. What is Marjolin ulcer?
Squamous cell carcinoma of the skin.
Okay.
Developing from a burn wound.
Yes, it's a type of malignancy of the skin. Thank you. Malignant changes in a chronic wound, like a burn scar ulcer, pressure ulcer, and venous leg ulcer. So this is Marjolin's ulcer. So little bit different pathophysiology, appearance of mass in the wound. So onset of wound pain not previously present. So change in character, volume, and appearance of drainage. If these changes there, better you can send the patient to the oncologist and take a biopsy and confirm whether the patients developed Marjolin's ulcer or not. If this is a curable cancer, so if these changes there, better you can refer the patient to the oncologist. So problems, we all know that this is an incurable ulcer. Physical problems will be there, psychological problems there, social problems there, and spiritual problems there. So these are the physical problems might develop these kind of patients, because pain will be there because of the sometimes the tumor will be compressing the blood vessels and nerves. That time the patients might have experienced neuropathic pain, and direct exposure of the dermis can cause nociceptive pain. So these kind of, so when we assess pain, you have to assess pain well, whether the patient is having nociceptive pain or neuropathic pain. So if you assess well, then you can able to manage well. And malodor is also again, so there is a lot of devitalized necrotic tissues in this kind of wounds, so that can cause malodor. And also the tail exudate dressings have been placed in number of days, can cause malodor. Bleeding we already discussed. Again, this major tumor will be protruding the major blood vessels. So maybe that is the another cause of bleeding. And exudates, again, there is a dilatation of blood vessels within the tumor. That can cause exudate, because lot of exudates will be there oozing. So this will be affecting the patient and the family. Again, malodor is also affecting the patient and the family. Nobody is willing to sit near to the patient, and so these all will be affecting the patient emotionally. Because of my distress, nobody is willing to come near to me, and these all things will be there. And infestation with maggots sometimes, and communication difficulties, because this patient is also having a buccal mucosa. Again, the patient is not able to talk to you clearly. So what you can do is, you can give a sheet of paper and ask them to write down their problems, so that they can able to, if they are able to. So otherwise, non-verbal expressions, from their non-verbal expressions, you can able to treat. And coming to the psychological part, again, altered body image is also affecting the patient psychologically and emotionally. And sexuality, denial will be there, fear will be there, depression will be there, anxiety, what is going to be next. And so these shame will be there, guilt feeling will be there. So these all comes under in psychological. What you can do is, if you do the proper assessment, if possible, you can do the individual assessment, because in front of the caregivers, they will be hiding the truth. So if you do the individual assessment, they will be telling the truth. So again, coming to the social problems, family isolation, social isolation, these all things, because if someone's developed these kind of problems, they will the family will choose family members will choose a corner side room and keep the patient there. So they will not allow the patient to enter into the kitchen or a dining area. Also, they will keep the tell the patient to keep. You have to lie down here all the times, and you have to, if you want and if you need anything, you please call us. So these are the instructions they will give to to the patients. This will be affecting the patient emotionally. And social isolation. Friends and relatives are not willing to visit these kind of patients, maybe because of misconception of disease. And these maybe sexual will be affecting sexual relationship and marital disharmony, because nobody is willing to get a person, maybe willing to marry a person from this kind of family because of the hereditary problems and that. So these all will be affecting the patient, affected because of me only my daughter is not getting marriage. And coming to the spiritual again, so then why me, these kind of spiritual questions will be there because God punished, why God punished me like this, because of my sin God punished me like this. These kind of spiritual questions will be there. So what you can do is, if possible, you can do the individual assessment. If you do the individual assessment, you will get a good idea about a patient problems. Again, assessment is also important. The management try to reduce their problems. If you do the assessment, you can get a good idea about the problems, and then based on the assessment, you have to try to reduce their problems. Our aim is to relieving the symptoms. If you are the main aim is to improve the quality of life of the patient and their family. No, so if you if they have a problems there, the physical problems there, try to reduce their problems. Then if you can able to reduce their problems, definitely we can able to improve the quality of life. Again, holistic care is also here. 4 aspects you have to cover: empowering the patient and family in wound care. So this is all. I think you all know that here empathetic care is also is mandatory. You have to think about the patient side, and if possible, you can ask them to take a thorough bath, so that these kind of wounds are fragile. So without touching the wound, if there is a necrotic tissue on their wound, so that will fall off. So if they are able to take a bath, you can ask them to take a good bath. So, and also you have to think about the analgesic analgesia, because if they have a pain there, you have to give some analgesics and then you can do the dressing. So minimizing pain, again, if a patient is having deep pain there, you can use the systemic analgesics. And if there is a superficial pain like nociceptive pain, burning, pricking type of pain there, then you can use the local application like Sensorcaine or Nicnocaine. If there is a malodor there, then you can use metronidazole. Metronidazole is a drug of choice of controlling this kind of anaerobic bacterial infection. So you can use metronidazole powder, and you can use metronidazole irrigation also, because there are a lot of pocket formation inside the area. Your metronidazole powder will not because that you can able to sprinkle and the top superficial the top area. If you use the metronidazole irrigation injection, this will go into the pocket formation areas and reduce the foul smell and all. And you can think about a course of antibiotic. Again, there is a less that blood circulation in the top of the area. It will not help fully, but you can try your own course of antibiotics. Again, here also no hydrogen peroxide and betadine. Always you have to think about the charcoal dressings. So charcoal is the good agent for controlling for the malodor. Bleeding also, always try to prevent bleeding. If there is a bleeding there, you can apply local pressure, and then you can think about sucral fit powders, the same drug which we have used for peptic ulcer. So, and then you can think about tranexamic acid, and if these not help, then you can think about systemic ethamsulate. And palliative radiotherapy is also helpful. If you do the radiotherapy, this will help to strengthen the size of the tumor. That way we can able to prevent bleeding. And always you have to instruct the patient caregivers about keep a dark color cloth. So they have to keep a dark color cloth in the house, because if there is a profuse bleeding there, they have to use the dark color cloth for wipe out the blood, because we can able to reduce the anxiety. Otherwise they will be panic, and if they are using white color clothes, the blood is red color, so the others will, patient and the other family members will be in panic. So so that anxiety we can reduce if you can use a dark color clothes. Again, so role of cancer therapy is radiotherapy and cytotoxic chemotherapy, hormone therapy, and surgery. So these will help to, so these three are help to strengthen the size of the tumor. And surgery, debulking surgery, if the patient's health status is okay, then you can think about the surgery. We already discussed about maggots, so always try to prevent the maggot formation. So the patient caregivers doesn't know how does maggots come, and the patient also doesn't know. So you have to tell them how to prevent the maggots. They have to keep cover the wound all the time, so that we can able to prevent maggots, because the maggots that can come from house fly. So if you cover the wound properly, it will not happen. So if there is a maggots there, they can use the turpentine oil. So you can use turpentine. You can soak the turpentine oil with the gauze piece and keep close to the wound, so that the maggots will come out. So that you can easy to the physical removal is the only way to remove the maggots. So the another important message: don't follow maggots, because there are a lot of pocket formation inside there. When you go with your artery forces, they go inside and keep safe there. If you go follow maggots, what happen? Your artery forces will damage the blood vessels. So when they come out, you can take it out. Otherwise, leave it. So after a few minutes, they will come out. So you can use turpentine oil. Thank you. Any doubts?
I think now we will watch a video on end of life care. Okay, I'm going to share it. Any comments? Any comments? So I hope you understood how to communicate about dying with a patient, and what needs to be discussed, um, um, and a patient may have many concerns which they want to share with us. So it is important for us to give truthful reply to all the issues, and if we are able to suggest some solution, that would be good. And I can see there is a question regarding, should we include family in this meeting? Yes, if the patient is comfortable, include the family. And this discussion with the patient about dying, this will not happen with everybody. This will happen with only a rare patient, because family would not allow you to talk about this. So this is another problem that we are going to face. Okay. So I think we can move on to the patient story, and then we will have a discussion on that, and possibly, if the time permits, we can have discussion on this video later. So today's patient story is going to be presented by Dr. Prarthana. Dr. Pratana, it's over to you.
Thank you, sir. Good evening. I'm Dr. Pratna. I'll be talking on this patient we had recently. She was a 54-year-old lady. She had recurrent progressive glioblastoma multiforme. When she presented to us, she was brought to us because she had altered sensorium, inability to take oral feeds, and she had an ulcer in the gluteal region. And about her story, she was diagnosed in 2020 with glioblastoma multiforme. She was treated elsewhere, not with us. She had undergone total excision, concurrent chemo radiation, and she had adjuvant temozolomide chemotherapy. After this, for 2 years, she had disease-free survival. She had good performance status during that time. Then she recurred in 2022 August, and she was offered chemotherapy, PCV regimen, plus bevacizumab. On this, she was all right for 11 cycles. She was ambulant. She was feeding. She was taking care of herself. She was communicating. She was cheerful. After that, in July this year, after 11 months, she started progressing rapidly. She started getting seizures on and off, controlled with 2 anti-epileptics, and her sensorium was gradually worsening, and she became bedbound. And she had been bedbound for 2 weeks. When she was the reason she was brought to us was that she had been her husband had taken her to multiple hospitals and to get some hope, to get some next line of management. When that was not offered and only palliative care was suggested, only supportive care was suggested, he shifted to our center, hoping she would get another line of management. On examination, her Glasgow Coma scale was 8/15. She had spontaneous eye movements when she presented to us, but the next day she had eye movements only when she was called. After 2 days, she had eye movements only when she had pain. Eye opening only when she had pain. She was not oriented. She was not obeying commands. Otherwise, vitally, she was stable. BP, temperature, and pulse, everything was regular and stable. Other system examinations were normal, but she had a right gluteal region ulcer, only skin peeling, and she had multiple color changes, bluish discolorations at prior venipuncture sites. She had already had a CT brain outside, which had shown progressive tumor involving her left parietal lobe, both occipital lobes, brainstem extension with cerebral edema. We didn't repeat her imaging. It was discussed in tumor board. It was decided that further cancer-directed treatment will be futile, and she was advised supportive care. So the treatment we had advised for her, but she was admitted in a private room. She was accompanied by her husband, her daughter, and son. Air mattress was made to lie down in air mattress. Position change was given every 2 hours. Pressure sore was cleaned with normal saline. Skin care was given every 2 hours, given thrice a day. Glycerin application was given to her lips because lips were dry and cracked. So the main challenges we had with this patient were that when we first saw the patient, for the first time when we met, she was unable to communicate, she was not conscious or oriented. So the husband had to make decisions on her behalf. So we had no way of knowing what kind of person she was or what she would have expected. And according to the husband, she had not thought of death or dying. She had been hopeful that her husband will get some help for her and she will survive. The next challenge we had was building rapport with the family and building the trust with them, because we had never met them before or during better times, and now they had come to us hoping that we would offer next line of management, not for palliative care. So it was difficult to build that trust. Next challenge we had was that husband was feeling very guilty because he was stopping treatment and that way failing his family, because his children believed he would get her some help. She believed he would get her some help. So it was very difficult for the husband to accept uh, palliative care at this point. He wanted some other line of management. He was willing to spend beyond his means and he was trying to get multiple opinions. Another concern was that for 1 week the patient had not been able to swallow anything fed to her. Before that, she was able to swallow even if she was not quite conscious. But now, whenever they gave her something, she had kept keeping it in her mouth. She was not able to swallow. So they were worried that they were depriving her of feed. They were starving her. So initially, we tried explaining to them that feeding her was not going to help her. But since they kept giving her something, she kept aspirating on that. So and so thinking that it would negatively affect them during bereavement, we gave her an NG tube and let them feed her because they were feeling very upset that they were not able to feed her. So this is a middle-aged lady with recurrent progressive glioblastoma multiforme presenting to us for the first time with advanced disease with poor GCS and pressure source. She was worsening by the day, but the family was hopeful of recovery, willing to try anything to get another line of management. So points that need to be discussed are how do we help the family accept that further care will be futile, and how do we deal with the family's husband's feeling of guilt in giving up on her. He thinks he's giving up on her, though that is not true. How do we make him understand that? And withholding nourishment versus giving NG feeds in a patient like this. And how do we talk about end of life and bereavement support when they're not able to accept that it's their end of life?
Okay, thank you, Dr. Prarthana. So we have a lady here in the 50s who has a recurrent glioblastoma. And the oncologist now opined that there is no treatment that is going to be helpful for her. So the husband and the other family members find it difficult to accept, and there are other concerns regarding feeding and guilt of the husband. So, what can be done? These are the questions. What are the can anybody comment on this questions that Dr. Pratana has asked? How to help the family to accept, and also how to deal with the patient's husband's guilt. What would you do in your clinical practice? Are there any oncologists, any other oncologists in this group other than Dr. Pratana?
Yes, sir.
Yeah, how do you manage? Because this is something which comes very frequently, and this is very common in our situation, and you will also face a lot of this questions and scenarios.
Yes, sir. Frequently, I too deal with these kinds of situations. It is actually very difficult to explain to a patient whom you have not treated previously. Or already this patient was treated elsewhere, and when it comes to the end of their life, they come to another center feeling that the initial center has not given them any benefit. So this usually happens, and how I try to explain them is through actual Actually, I will try to explain what this disease is and how it natural history of what is the natural history of this glioblastoma multiforme and what a poor prognosis it carries by actual data in months. So I will tell them to to understand that they have done their best till now with all the drugs which are available has been already given to the patient. So what they think is not actually going to help the patient now, and what she requires is like more of a supportive, not just like an empathetic and just a supportive care rather than more invasive things or invasive managements or admissions in the hospitals like that. Okay. So
Okay. Yeah. Please go on.
yeah, so I will tell to the husband that this is actually the natural history you can see in any patient with glioblastoma multiforme wherever she is treated. So towards the end of life, when nothing can be provided to the patient, being hopeful is not the thing that is required now. And the thing is actually beyond the hope, and it's time to accept and understand the reality, and to help the children also understand the same thing. And nutrition or NG2 feeding or hospital admissions or seizure management, nothing is going to help the patient rather than financially draining them a lot at present. So it is not abandoning the patient, it is not actually giving up, it is actually accepting that end stage and providing a peaceful end to the patient.
Okay, thank you, Dr. Anju. Those are very important points. Anybody else want to comment? How are you going to talk to this caregiver, husband and family about this? Anybody? Okay. So there are a few things which we need to understand. What Dr. Anju described are facts. But yeah, that we always need those facts. But here the family or the caregiver, husband, is not accepting the fact. But also, what we need to understand is, in a serious illness, um, there are various stages through which patient and family goes through. And this is, these stages are described by Elizabeth Kubler-Ross as DAB. DAB, D for denial. So whenever you have a serious disease, first of all, your reaction is to, no, I don't have it. That is denial. Then next, A for anger. Then bargaining. Bargaining means if I will not smoke till from tomorrow onwards. So please cure my disease. Uh, so that's bargaining. Then there is denial. Depression. Then acceptance. So these are the 5 stages described in relation with serious illness. And uh, these stages will not come in order. Uh, some patients may directly go to family may directly go to acceptance, but some patients and families go through various stages, and they may not come to acceptance at all. Um, and so this is what you have to understand. Acceptance is not in our hands. it is with them. We can only facilitate to come to an acceptance. But whether will they accept or not, that will depend on many factors. And the husband is feeling that because we are not giving any treatment, and he thinks that treatment can, or even I think this would be the situation where he is pressurizing the oncologist to give some type of therapy. So what I would do is, as Dr. Anju told, we can talk about the facts, but I would also tell another thing, that suppose if I am agreeing to give chemotherapy, what all problems are we going to produce for this patient? So I would tell him that by giving chemotherapy at this stage, even I will kill the patient. Uh, so uh, it is not going to be beneficial for her in any way. So when we compare the benefits and the risk of giving chemotherapy, it is going to be more harmful for the patient. Do you agree to produce more harm or more side effect for your loved one, for your wife? So this is how I would deal it, even with the facts that Dr. Anju has told us. But I think this we would need this to make him understand that even if he gives chemotherapy, that is not going to help her. It is going to make her condition worse, and that's the opinion that they have got from other hospitals also. And withholding nourishment was nasogastric feeds. Dr. Prarthana, do you have any comments on what I said? Or
Sir,
Dr.
about
Anju?
NG feeds? Sir, is it about NG feeds?
No, the previous 2 points.
Yes, sir, that's all right, sir.
Dr.
We
Anju,
actually 3 counseling sessions with him. So at the end of it, he accepted supportive care, but later he booked an appointment in another hospital and took her there to get an opinion when she was very sick. But we were not able to convince him. We tried explaining data, the prognosis, all that, but we didn't talk to him like saying giving chemo may kill her. That we didn't tell, like it can go that far. We didn't explain like that.
Okay. Yeah. Maybe because we are now talking from the patient side, we don't want patient to suffer anymore, and we also 100% believe that this is not going to be beneficial. So it is our duty to tell them, okay, what is the thing that can happen. Yeah. Even after your explanation, there are some patients and families who would like to take opinions. So we cannot help with that. And withholding nourishment versus nasogastric feeds, this is a very important topic and very difficult topic. What I would tell the patient's caregiver is that, so first of all, we have to understand that giving food is an act of love, isn't it? So if uh, some of us goes to any of your comes to any of your home, you will give us something, maybe a tea or something like that. So it's we are expressing our love, and you can see the mother feeds the children and the wife feeds the husband. So many things. So these all are acts of love. So if the patient is not taking, it is very difficult for the family to see that their loved one is not taking anything. But what we have to tell them, so first of all, you have to empathize with them. Yeah, it would be very difficult for you to see that your loved one is not eating anything. That may be the first statement that can come from you. And then I think you should talk to him regarding the benefits and side effects or harmful effects of uh, putting a rice tube and feeding at this stage. So what all can you tell at this stage? So maybe one thing is that you can talk about the requirement of energy, and because this patient is bedridden, so you can tell him that okay, at this stage, suppose why we need food. Food is to produce energy because we would need to do many things. So we are walking, running, thinking, doing jobs. So we would need higher amount of energy. So we need to eat more. But a patient like your wife, she is just lying down. There is no activity. She doesn't require much energy. The energy is all what is needed is just to maintain the body functions. So that's all what is needed. So whatever she is taking little, the energy will get from that food. Um, then the second point I would bring is in case of I would compare the um, person along with cancer to a tree with a parasitic plant. So when the parasitic plant climb on the tree at first, the tree will not have any problem. But after some time, what happens? The tree will decay, and the parasite plant will grow. So this is what happens to the body when a patient is having advanced cancer. So in advanced cancer, what happens? Um, Even if you give food to the patient, uh, the cancer cells in the body is having high metabolic rate. So whatever food is giving, that is going to be utilized by the cancer cells, and normal cells may not be utilized much nutrients. So uh, even if you give the type of food, whatever good it may be, it is not going to be beneficial for the normal cells of the body, but uh, it will feed more to the cancer cells. Uh, and so this is another thing which I would tell them. And another thing would be in cancers and chronic diseases. Um, there are some chemical mediators which are produced in our body, which will uh, interact with the satiety center of the brain and will reduce the appetite. So that patient will not have any appetite uh, and they do not want to eat anything. So this is what is happening to your wife. She always feel that she is full, and if you put a rice tube and feed her, then there are a lot of things can happen. If you feed that can actually make her more discomfort by feeling fullness of abdomen. It may get aspirated. She may vomit, and even putting rice tube itself may be difficult for a patient who is not conscious. So these are some things which we can explain to the patient's caregiver and asking, are there any benefits? We do not find any benefits by feeding the patient. Which is more? Is it the benefit, or is it more of side effects or harm to the patient? Um, this is how you can go and talk to the husband regarding the uh, withholding nutrition versus rice too. And if she's in the last few days then I would not advise him to put rice tube. I will be against that. And we also need to understand that withholding food and fluid will be something which I told you culturally may not be good, and it would be very difficult for the caregiver to see that their loved ones are not taking any food. So maybe you can, what we do in such situation is we would tell the caregiver that we can give subcutaneous fluid. So we administer fluids through subcutaneous route, 500 ml per day. Because IV, it would be very difficult to get IV access in patients who are cachectic and who has received a lot of chemotherapy. Most of the veins would be fibrosed, and nurses need to poke many times. So all these are going to produce more and more pain for the patient. So subcutaneous fluid is something which we can give to any patient easily with one poke. So 500 ml of fluid can be given, and that will also give some relief to the caregiver that they are getting something. So this is how we usually addresses the problem of feeding. And yeah, and Dr. Prarthana?
Sir?
Any comments on this?
No, sir, nothing more, sir.
Anybody want to comment on anything that we have talked, or your opinions? Okay, so one of the clear indications that patient is actively dying is death fatigue, and sometimes delirium also. There is something called a terminal delirium, which occurs in almost 75% of the patients. But whether it is terminal delirium or just delirium, we can make it out mainly retrospectively. But if you are caring the patient for the last few months, then you would be the better person to judge whether it is a terminal delirium or not. Okay. Anything else? Okay, then I think we can wind up the session for today. So thank you, Dr. Prasana, for bringing this patient story, which was very apt for this particular session. And all these are very difficult questions, which we would face in our clinical practice, but many a times we would not be able to answer those questions or address those questions. So it is from a person who has been doing palliative care, or who has some experience in palliative care. I think it is important to be with the patient, but at the same time, we have to also look after the concerns of the caregiver. So it's a very difficult job for us. And thank you, Sheeba, for the wonderful session. And thank you, everybody. And it's over to Sripriya.
Thank you, Sister Sheeba. I personally know that you would have had a very tiring day, and still you found out time at the end of the day to interact with our participants and clear their doubts. Thank you so much for that. Thank you so much, everyone, for making the session interactive. And till the time we meeting in the next live session of our integrated course, this is Sripriya along with the Sister Sheeba and Dr. Sunil Kumar signing off from the Palliative Media's desk. Take care, everyone. Stay safe. Be happy. Bye-bye.